So we're just going to talk about a little bit about clinical trials, about the new drugs that are being approved, what's up on the horizon. So we asked Eric to join us, and then we have Rose over here who is on Zermela, and you were on the clinical trial, so we're going to ask her a few questions. Okay. So Eric, let's talk about Zermela, and could you explain the trial and how it came about and what the results were?
Sure. So Zermelo is a drug that's called Telotrestat. And it's actually a derivative of an old drug that was out in the 50s. The only problem is when they gave it back in the 50s, it caused suicidal depression. So clearly not something you would take every single day. So they kind of tinkered with it, and then they came up with this drug, and it's taken a long time, but they finally got it through. And basically what they found was that it was very, very specific for inhibiting the production of serotonin, not in the brain, because it doesn't penetrate. It only blocks a certain type of the enzyme. And it turns out this enzyme is very prevalent in small intestinal neuroendocrine tumors or these carcinoid tumors. And so they did a trial called Telestar. And what it is was they took a whole bunch of patients who had just known diarrhea from their carcinoid, like so high serotonin levels, very classic stuff. And then they gave it to them. And these people had, bowel movements between like 4, I can't remember the exact numbers, like 4 to 12 times a day. So it was like a very reasonable number. And the question was, I know, yeah, I guess you're right. I guess it depends, right? I know. If you're a man, it's like much more, but it's okay. And then what they did was they said, okay, so why don't you take it, they said, half the people will take it for 12 weeks, and the other half will take some placebo for 12 weeks, and we'll compare the two. And the reason they did it was because it was very short, right? So they didn't want the poor people who, were suffering to keep suffering. So they're very nice people. So, and they said, well, how many bowel movements did you have? How much extra, like, rescue octreotide did you need and stuff like that? And what they found was that if you took the Zermelo, which is what's called now, it would reduce your number of bowel movements by 1 to 2 bowel movements per day. And that is actually really pretty significant. So if you had 3 bowel movements a day, maybe it wasn't that big a deal. But if you had like 15 bowel movements a day, that was huge, right? So it was a huge, big deal, right? The people who are nodding their head. And so it was FDA approved for the diarrhea from carcinoid syndrome. It wasn't approved for anything else. It didn't work that well for flushing. But for the diarrhea, it actually worked pretty well. Now, you have to understand, quantitating diarrhea is not so easy, right? So is it like how many bowel movements you have? How many times does your bottom touch the toilet? I mean, it's difficult to figure out.
Do you make it to the bathroom?
Do you make it to the bathroom? Right. I mean, that's clearly, another issue. So it's not so easy, but it was approved, right? And that's actually the most important thing, that we have it available. And so since its approval, I think there have been like maybe 200 or 300 patients who've been given it, and I would say in general, the reception has been overwhelmingly positive. For the people for whom it works great, right? It really changes their lives. They feel much better. It's a pill you take 3 times a day, and you have to take it with meals. That's really important. So you take it 3 times a day, but it's a pill, right? So it's not a shot. And you have to take it in conjunction with the somatostatin analog. So it's an adjunct. But it's better than taking 2 shots, right? I'm sure there's some people in the room who get 2 shots, and it works better. So that's really the key. The side effects have been, at least in my opinion, in my observation, have been relatively minimal. It's been pretty well tolerated. And since it's kind of very, very new, there's still some quirks to work through, like insurance coverage and delivery. Those kinds of logistic types of things are being worked through. But in general, it seems like it's been a very positive thing. And I'm excited because it's a new tool for taking care of people who have to make their lives better, right? I told you that's a very high priority for me, so it's a new tool. Now, the complicated thing, though, which is why, Dr. Thor kind of mentioned this, was you've got to figure out actually what's causing the diarrhea, because there are lots of causes of diarrhea. And so this is why it's really good to see a neuroendocrine specialist, because we can usually kind of pick out the reasons why people have certain diarrhea. I think what Dr. Thor does, his trick is he tastes it, and depending on how it is, that helps it for him to figure out. Oh, where's Thor? Is he gone? Oh, did he leave? Oh, okay, well, man.
He missed it.
That's a zinger. Anyway, but usually we can kind of pick out what the different kind of causes are. Now, Zermello does not fix short gut syndrome. Zermello does not fix bacterial overgrowth. Zermello does not fix bile diarrhea. It doesn't fix those things. It doesn't fix pancreatic insufficiency. So you got to figure out what the real causes are. But someone who does this every day, 4 times a week, whatever, what he said, 4 or 5 times new patients a week. Those are the people you want to see because we can sniff through it much faster for you and get you on the right path.
Yes, and I think it's very important that you remember, going back to being your own advocate, is that when a doctor asks you the question of how is your diarrhea, a lot of us only think about the 2 days before we saw the doctor. You really should keep some kind of journal and have a better idea of what's going on before going to the doctor, because I think a lot of people get that white coat syndrome. When that doctor walks in the room, it's like, oh no, everything's fine. No problems. No diarrhea. I think I've been okay. Have you had any flushing? No. In the meantime, you're like bright red and your ears are burning and things like that. So try to keep like a diary if you notice that you're having a lot of diarrhea, and make sure that you let the doctors know, because like he said, it may be due to pancreatic enzymes you might need or something else. So make sure you let the doctors know.
If I can make a point, just one point, it is critically and crucially important for you to have a dialogue with your physician. And if your physician won't listen, you got to find the nurse. And if that nurse doesn't listen, find some other nurse. I mean, you've got to talk to these people, because I don't think it's uncommon for people to see the doctor for like maybe 4 or 5 minutes, right? And then in those 4 or 5 minutes, you're so rushed, you're getting scans, you're talking about labs and stuff like that. You don't talk about how you feel. So what Marion says is 100% correct, but really you have to take control of that visit. Remember, you're paying that doctor for that doctor's time, right? So for example, when you fly to see me, most new patients, they get a whole hour, because it takes an hour for them to just kind of get to the point. I mean, really, I'm not kidding. This is how it is. This is how the conversation is. But if I used to do it faster, and I would miss stuff because the patient wouldn't tell me stuff all the time. So I said, okay, fine, I'll just sit, I'll just listen, and I'll see what they have to say. And then that's when the truth actually comes out, and you spend enough time doing that.
Right.
So do it.
Yeah, make sure that you let them know everything. And don't always assume that your symptoms have something to do with your NET or carcinoid, because there are other things that can cause symptoms. And I know I'm guilty of it all the time. I was diagnosed with lupus in 1990, and I just pushed off a lot of things to my lupus. And had I not, and I told the doctors a little earlier, it might have picked up my tumor a little bit earlier. So just don't always assume it's definitely whatever, that it's related to your NET. It might not be. So Rose, what were you diagnosed with and when, and why did you go on the trial?
I was diagnosed in 2012 with small bowel carcinoid tumor. They found it on accident. I went in for a different surgery and they found it on accident. So I woke up to hear, you have cancer, but it's the good kind.
Not really.
Yeah. Sorry. I went on the clinical trial because I believe that they cannot find the solution unless we put ourselves out. We have to be willing to travel. We have to be willing to take drugs 3 times a day, to write it down in a diary, to see the doctor a zillion extra times. If we don't participate, there's no solution for us, and we don't get a complaint. It's like not voting. And then, you look who's president. So we're very passionate about that in our family. I was very, very fortunate. I was pursuing getting in a gallium-68 trial down at Stanford, and I pursued that for 3 to 6 months, and finally I got in, and I went down to see Dr. Pamela Kuntz, and she recruited me for the telotrestat trial at that visit. I was lucky.
So has it helped you?
It has actually helped me enormously. I still have very bad diarrhea, but usually I make it to the bathroom. But I don't think you can tell now, but it's really helped with my flushing, which is so interesting that they say that it wasn't that helpful for flushing. But I had a terrible time flushing and flushed all the time when my color would go up and down at work and everybody would stop and look at me. And with the flushing, you're short of breath and you're exhausted all the time. So it's really helped there. And I think it's kind of moderated. It's moderated the diarrhea, but I probably need to go see Eric.
Can I make one more point? It's an interesting point that she makes, is that sometimes you've forgotten how miserable you are, right? Because you're like, oh, I've been dealing with this for like 4 or 5, 6, 7 years, right?
Yeah.
And then this is like a new quote unquote baseline for you, which is not right, right? It is not normal for you to be like thinking about which bathroom you're going to as you drive down I-5 or whatever that miserable trafficy road is here, right? And I can tell, you can tell a person who has carcinoid because they know every single bathroom and every single Safeway all along the way. Right?
And we know which ones are locked.
So sometimes you have to just think, is there something that can get me? So, you know, obviously, I mean, I tease a little bit, but surgery is a phenomenally powerful tool to get rid of a lot of tumor burden. It's not perfect, but it gets rid of a lot of tumor burden. This PERT, this Zermelo, this somatostatin analog. I mean, I can only say this so many times. The number one thing we should always worry about is, or work on, is your quality of life. And the second thing we should work on is your quantity of life. And so if you always think about it in that frame, then should always explore options to making you feel better.
So you've had good results and you're happy with it. Did you have a lot of side effects?
I didn't have any side effects. I have felt great throughout it, and if I could just add, I went over there to say thank you for putting me on the trial, for the medicine, but the thing is, it's given me access to better medical care than I had here, to a doctor who knows a lot more, and my doctor works so beautifully with her. So that, there's your side effect.
That's perfect. That's perfect. Okay, Eric, can you talk about the other clinical trials that are on the horizon?
Yeah, so obviously we've had a lot of things happen in the past year or two in neuroendocrine, PRT, Zermelo, gallium. I mean, it's been a lot going on. As far as the other clinical trials that are going on, it's slowed down just a little bit. These are the kind of the big things. The most glamorous one is this oncolytic virus that people are talking about, which is what they're testing in Sweden. It is very, very early in testing. No one's been cured of it yet, so just hang tight. But the person who's running the trial is a very dear friend of mine. So I promise when he's ready to bust the doors open, I'll let you know. The other things that are interesting, the interesting thing is there continues to be growing interest in it, right? And so we're very fortunate to have people like Dr. Thor and Dr. Coons and these other people who are medical oncologists. What they do very, very well is they do clinical trials very well, right? So they put these things together, they toss you guys into it, and then we figure out what works and doesn't. So if you can participate, please by all means try to participate because it helps us a lot. It may not always help you, but it does help us a lot. So what else is coming through? So there are other small molecules that are being tested. The immunotherapy, like Dr. Thor had mentioned, is very interesting. It's not perfect, but it's very interesting. There's a trial in high grade looking at temozolomide even for high grade neuroendocrine cancers. There's a trial looking at it's very early, but there's an interesting octreotide conjugated to a poison rather than to a radioactive. There is hopefully there is a lanreotide trial right now in lung specifically because we don't have any indications or that much data in lung. There are let's see what else. Anyone else think of anything else? I can't think of anything else. I mean, big ones. There are lots of little small things coming along. Yeah.
My daughter found on the internet clinical trial in Maryland, and I thought it was on the
The gallium.
Gallium.
gallium scan. I know she sent information back.
So that's a little different. That's an old scan. That's an old study. It's not really a study anymore. It's at the NIH, and it's in Bethesda, Maryland, my hometown. And what they're doing, they have a trial. The gallium part of it is not a trial anymore. Hopefully, there's no question anymore. Even if I can convince Thor, I can convince anybody. But really, what they're interested in looking at the difference between everolimus and sunitinib. So they have a trial like sticking you in one and sticking you in the other, and find depending on certain genetic information. And that's kind of going on, but that's with 2 drugs that are FDA approved already. So it's not like there's like something magical or new coming along.
And what does it take to get onto a clinical trial?
That's not so easy. A lot of it's geography. And so if you're lucky, like the Zermelo trial was a little bit easier because you didn't have to live in the town in order to get it. But a lot of the places you have to live in the city because you're going to get therapy 2 or 3 times a month, right? So it's actually very difficult and complicated. The various immunotherapies, for example, it's usually about every 2 weeks to get the infusion of nivolumab is the one drug. And then there's another drug called Keytruda. What's Keytruda's called? Pembrolizumab. And then there's this other drug, which is the Novartis version, which is coming out. So it's labor intensive. To get involved is actually not that complicated. All you have to do is go to clinicaltrials.gov, hunt for the thing you're looking for, and call the company. The problem is if you don't have a place close to you, it's very difficult. I'm very fortunate. I'm not a fancy academician like these people are. I'm just a regular city country doctor. And no, I am. I'm a community doctor. That's all. I'm not anything fancy. But I'm very fortunate because I work with 1,400 medical oncology partners across the United States called US Oncology. It's a system that we have. And we have actually, I think probably the most clinical trials open, and most accessible in the community. So for example, if I have a clinical trial that I was working on and we want to open it, say in Cincinnati, we can, if we identify the patient, I send them back home, I can open the trial in 2 weeks, and then they would get it. So there are certain advantages to being in different types of systems, but it all depends.
And what are our rights as patients on clinical trials? Do we have a right to say to the doctor in the middle of the trial that we no longer want to do it?
Of course, right? So the one thing you should always do is when you get it, you should read the consent. Read the consent. Read it once, read it twice, read it 3 times, right? You spend a lot of time in the toilet probably, right? So go ahead and just take it and read it with you. Was that? Just kidding. And kind of not. So, but you should read the consent form very thoroughly, okay? Because the most important thing you should understand, sometimes when you do clinical trials, you're doing it, like I said before, as a favor to this field of science, okay? You may not be getting, because it's a clinical trial, right? They don't really know if it's going to be effective for you or not. Do you know how many drugs actually get from the mouse to the human? Like 1%. A lot of them either hurt people along the way so they have to stop it, or it doesn't work at all. So there's a trial aspect to it. So you should always know, it says it very clearly, you may always stop the clinical trial and never be afraid of like having retribution or something like that. Because first of all, that's wrong. That's just wrong. But they say it very clearly. This was all delineated in what we call the Helsinki Act, I can't remember, of 1971. I can't remember exactly the date or whatever it was. But anyway, this has been very worked out because we're not in the business to experiment on people. We do because you have to do human research, right? I mean, there have been a lot of mice who've been cured of cancer, but their insurance is terrible. So just keep that in mind.
Well, we'd like to thank you both for joining us. And we are going to ask Carrie Bernto and Rhonda